talking about Orm's self-care deficit theory. I'm Jonathan.
I'm Tarshira.
And I'm Leslie.
So Orm's model of nursing was developed between 1959 and 2001 by Dorothea Orm. The theory is based on human beings' ability to adapt to their environment, and it originated from the totality paradigm. Her goal was to improve the care at general hospitals in her state. The purpose of the theory is to guide nursing care to promote self-care within the confines of various self-care deficits. Assumptions from this theory include things such as people should be self-reliant and responsible for themselves. People are distinct individuals. Nursing is a form of action or interaction between two or more persons. Successfully meeting universal and development self-care requisites are important components for primary care prevention and ill health. A person's knowledge of health is necessary for promoting self-care behaviors, and self-care and dependent care are behaviors learned within a sociocultural context.
Orm's self-care deficit theory is a grand theory, broad and general nursing theory. It's a balance between self-care abilities and universal self-care needs. There's specialized impressions of universal care requisites that have been particularized for developmental process, or they are new requisites derived from a condition or associated with an event. Healthcare deviation self-care requisite are required in conditions of illnesses, injuries, or diseases, or may result from medical measures required to diagnose and correct the condition. The three basic nursing systems: Wholly compensated compensatory nursing system. A person with these limitations are socially dependent on others for their continued existence and well-being. Partially compensatory nursing system is either the patient or the nurse have the major role in performance of care measures. In the supportive educative system, they're able to perform or should learn to perform required measures of internally or externally oriented therapeutic self-care, but cannot do so without assistance. Is the concepts operational? Yes. When you have a patient come into your practice, you look at their demands, you see what they're capable of doing, and then you look at the deficits. This is where we set up the plan of care. And as a nurse, you look if they can help their needs individually, partially, or you supply teaching and supportive education as far as rehabilitation, outside resources, home health care.
So what is the relationship between concepts of theory? Or self-care theory encompasses a patient coming into our practice, the primary care practice to be more specific. The patient comes in because they present with a deficit. That deficit leads us as a nurse practitioner to a diagnosis that is built on self-care demands. There's a need, a deficit, a disease, an illness. Then from there, we must determine how can we get the patient back at the baseline, independent self-care. So we also look at other self-care agencies such as rehabilitation care or home health care to assist with this process of achieving the outcome of independent self-care. So Orm's self-care deficit theory is broad and can be generalized in any practice when caring for a patient. The theory highlights the balance of self-care abilities and universal self-care needs, and is consistent and adequate as we all know that human needs occur on a daily continuum. As we relate to the physiological needs as depicted in Maslow's hierarchy of needs, So, is the theory clear and concise? Of course it is. It has major concepts that are explained in depth. The linkages between the concepts are easy to grasp and understand. So, can the theory guide practice? Is it predictive? Is it generalizable? Of course, it's all of that. When we have a patient that presents to the primary care practice for a self-care deficit, we as nurse practitioners must first identify a problem. We identify there is a problem, there is a trend that we must look at to determine what the care is needed for the patient. We look at the self-care needs, self-care demands, and the self-care agencies that we can utilize to get the patient back to baseline, which is independent self-care.
Where is Waldo? He's at Beaver Medical Group, a primary care clinic on east side of 410. There's a nurse practitioner that's currently seeing a patient who's complaining of joint pain for the last 5 years with no medical treatment. She comes in and she complains it happens during the mornings. It is apparent the patient is not taking any medication to help resolve the pain. The nurse practitioner sees the patient and does a physical exam. Immediately, she notes self-care deficits. She attempts to try to help the patient with seeing what systems and agencies are available to assist with her care. She also noticed bad posture. Patients need education on her actual medical condition. Nurse practitioner diagnosed patient with rheumatoid arthritis and determines that she needs some outpatient rehab center care. As you can see to the lower right, there's a rehab center that's located right next to the Beaver Medical Group, the primary care location. The nurse practitioner employs those additional things and agencies to help the patient to return to baseline, which is self-care, being able to do basic activities of daily living. In Dorothea Orum's self-care deficit theory, she spoke about self-care agencies and self-care deficits that requires healthcare and rehabilitation centers. The patient that was last seen in a primary care clinic for pain and rheumatoid arthritis can no longer perform activities of daily living while living alone by herself. The nurse practitioner must now make a decision to admit the patient to a rehabilitation center with the hopes of the patient returning to baseline, which is independent living and the ability to perform
Where is Waldo? He is on the southwest side of San Antonio at the Shannon Family Medicine Clinic, where the nurse practitioner is seeing a patient with a diagnosis of end-stage renal disease. He is being dialyzed on Monday, Wednesday, and Fridays in an outpatient setting. The family and the patient agrees that he is no longer able to care for himself at home. The nurse practitioner has to set a plan of care in place so that the patient can be in a setting where he can be assisted with activities of daily living, as well as being transported to hemodialysis 3 days a week in an outpatient setting, and where the family can be involved in his care during the week and on the weekends. Dorothea Oram believed that people have a natural ability for self-care, and nursing should focus on affecting that ability. Patients with end-stage renal disease sometimes are not able to care for themselves in a home setting and are needed to be placed in a nursing home facility. In this facility, it promotes positive quality of care. Nurses have the ability to promote self-care and potential health outcomes and consider the lifestyle changes that have been made for this patient. Healthcare professionals who provide direct care, nurses can assist with these changes by providing educational opportunities and strategies that increase self-care, thus making a positive impact on a patient's quality of life.